homemaker, married for last 8 years and uneducated. She is Hindu by religion and a resident of 101 by 12 Daryaganj, New Delhi. She presented into the OPD on 15 June 2021 with chief complaints of shortness of breath for 1 year and occasional cough with sputum for 2 months. History of presenting illness. The patient was apparently well 1 year.
So there are two chief complaints. Am I audible to everyone? If there any problem with the, no, I am audible to you, but what about the other students who are not the presenter? So if there any problem, you can write in your chat box. I think I am audible and the other person, that Krishna Shish, is also audible to everyone. Please write in a chat box if we both are audible to you and the screen is visible to you. If nothing is there, I am assuming that we both are audible and the screen is visible to all of the students who are attending the case. Okay, go ahead. So there are two chief complaints. One is the shortness of breath for 1 year and occasional cough with sputum for 2 months. Okay. There is no other chief complaint?
No, sir.
Okay. Okay, go ahead.
So, history of presenting illness. The patient was apparently well 1 year back when she started developing shortness of breath on exertion. It was insidious in onset and gradually progressive in nature, such that initially the patient felt breathless only on strenuous exertion, for example, climbing a flight of stairs in a hurry, with no restriction in day-to-day life activities. The condition worsened gradually with slight limitation of day-to-day life activities, for example, while washing clothes and sweeping the floor, since the last 6 months. Now, since last month, she becomes breathless even while walking from one room to another, thus causing a marked restriction of day-to-day activities. Breathlessness is resolved completely on resting for a few minutes. There is history of intermittent attacks of breathlessness at night, causing her to wake up and gasp for air. There is no seasonal or diurnal variation observed.
Wait,
yes, sir.
wait, Krishnashish. There are 1 or 2 points which needs to be resolved here.
Yes, sir.
Okay. First is, you said that there is the condition worsen gradually. Okay.
Yes, sir. Yes, sir.
She become breathless even while walking from one room to other room.
Yes, sir.
Okay. That means you want to say that the breathlessness is gradually progressive.
Yes, sir.
Is it all right?
Yes, sir.
Yo. So you have to gauge that breathlessness on some scale. That
yes, sir.
From the starting, means 1 year back, the patient breathlessness was so much. All right. And after 1 year, the breathlessness is on the scale of something is like that.
So, in the third point, sir, it is basically representing NYHA grade 1 shortness of breath.
Exactly.
In the fourth point, yes.
That's what I want to say you, that you have to gauge it with some scale. As you say, it is NYHA grade, so apply the NYHA grade. You have write it something. Okay, you have written it all right, but after that you have to say that 1 year back the breathlessness was of grade, let's say 1 or grade 2 according to your history, and over a period of 1 year the breathlessness gradually progressed from NYHA grade 2 to grade 3 or grade 4. Okay, I think there is no breathlessness while the patient is resting.
Yes, sir. It has progressed from NYHA 1 to NYHA 3 over a period of 1 year.
Over a period of 1 year. So you have to mention it. Okay. If you want to apply that NYHA grading, then NYHA say it's NYHA grading, or if you want to apply some other grading, MRC or any other grading, then that is up to you. But But whenever you present a case of a valvular heart disease, it's always better to use a NYHA grading. You have to write the NYHA grading also. Okay.
Okay.
Okay. Go ahead.
So, no history of breathlessness on lying flat. She also complained of occasional
Again,
cough for last
again,
two.
again, again, again. This point has to be elaborate. As I understand, you want to say that there is a history of paroxysmal nocturnal dyspnea.
Yes, sir.
Yes. So you have to elaborate that episode. That when the breathlessness occur, at what time of night breathlessness occur, how the breathlessness goes, is it resolved spontaneously, is it is it resolved with some medication, what happened to that breathlessness. So you have to say 2-3 points about the PND, and then
Sir,
what are the episodes with which the patient present, means what is the frequency of that PND, means let's say 1 month 1 year back the episode says, patient says कि एक महीने में कभी एक बार होता है ना.
okay.
But now these attacks comes every week or twice in a week. So that also suggests that the disease is progressively
Progressing.
increasing. Okay, so explain that PND part
Sir,
and
characteristically,
and
the
and orthopnea also.
so characteristically, a patient of PND should present like this, that he goes to
No, no,
sleep
no,
or
no. In what happened? No, no. Krishna says what happened in this patient.
So in this patient, so this is a hypothetical case. So and I was not sure how much details the patient can give regarding the episode.
No, that episode you have to extract. You have to ask the questions. What was the episode? How does it resolve? Patient does not tell you. He doesn't know anything about the PND. He doesn't have any idea what is the PND is all about and what is its significance. It is the student or it is the examiner or the clinician, that is the clinician work to extract the history. So you have to ask specific questions. What is the episode? What was the episode? What it look like? The episode is look like, how frequent it comes, and how does it resolve. 4-5 questions you have to ask. Then the specific answer comes. भाई आप उससे अगर पूछोगे कि जो ब्रेथलेसनेस है, जो आपको ये अटैक हुआ, ये अपने आप चला जाता है या मेडिकेशंस लेने के बाद जाता है, वो आपको बताएगा मेडिकेशंस के बाद जाता है या अपने आप जाता है. Yes or no?
Yes, sir.
So this question you have to ask. Okay. So, okay. Go ahead. What is the typical PND attack?
So the patient goes to sleep, and after about 90 minutes, the patient starts experiencing breathlessness, and he wakes up, gasps for air with his legs hanging around the side of the bed, or he may even move on to the window for better air, and when he rests, rest for some time or take some medication depending upon the severity, the breathlessness resolves by itself.
This point 90 minutes, make it 2 to 3 hours.
Okay.
Okay, 90 minutes. It seems that everything occur after 90 minutes. It should not be like this. ऐसा नहीं है ना कि 90 मिनट के बाद में उसको कुछ होना शुरू होगा. किसी को 2 घंटे में भी हो सकता है, किसी को 3 घंटे में भी हो सकता है, किसी को 2.5 घंटे में भी हो सकता है. So make it 2 to 3 hours. Okay.
Okay.
So what is the difference between the attack of PND and the attack of let's say pulmonary edema? What is the difference? How will you differentiate whether this episode is a PND episode or it is a pulmonary edema?
Sir, generally, if the patient already has pulmonary edema, the moment he lies down, if it lies down flat, he would start experiencing breathlessness. But if the in cases of PND, when he's lying down, at that moment he doesn't have any breathlessness. But over the after 2 to 3 hours, then you will suddenly start having shortness of breath.
No. Something else is there. How does a patient of pulmonary edema present? What are the presentations of patients suffering from pulmonary edema?
So shortness of breath, cough.
What type of cough?
Sir, uh, uh, sir, frothy,
Yes, yes, good.
frothy
It is
productive cough.
no, it is
Frothy,
pink frothy
pink
sputum.
frothy.
Pink frothy sputum does not produce in patients of PND. Okay. Why the sputum is pink and frothy? We have discussed in
Sir,
last class also.
yes, sir. Sir, regarding the pink part, sir, what happens is that after pulmonary congestion, it can it will have increased pressure on pulmonary capillaries. So there will be slight damage to the walls, and RBCs will leak out. And so there is a slight pinkish tinge to it, and because it is a little amount of fluid in the alveoli, plus there is gush of air, so it will generate the froth.
Good. So all these things will not happen in patients of PND.
PND.
Okay. PND may resolve itself or with the medication, or it may progress further to pulmonary edema also.
Yes.
Okay. So that's why it is important to control the episodes of PND. What about the orthopnea? Tell me something about orthopnea.
So in orthopnea, generally it happens in the later stages of congestive heart failure. What would happen is that because of when the patient is lying down, the moment the patient lies down, there will be increased pooling of blood in the pulmonary vasculature, and there will be edema, and the patient would start having breathlessness. To compensate for that, or to adapt to it, what the patient does is, if the patient does not give history about regarding the breathlessness on lying down, we can also ask the history, like is he keeping pillows, one or two or three pillows to avoid lying totally supine.
So how will you ask the history of that orthopnea?
So I can ask him कि जब आप लेटते हो, रात को सोने जाते हो, लेटते हो, तो फिर आपको सांस लेने में ज्यादा तकलीफ बढ़ जाती है क्या? Generally, this orthopnea patient will even have breathlessness on rest, might have breathlessness on rest also. So we have to ask कि क्या बढ़ती है जब आप लेटते हो, रात को सोने जाते हो तो बढ़ जाती है. If he denies, then we can ask क्या पहले होती थी और आप तकिया लगाते हो 2 या 3, अगर तकिए लगाते हो तो कितने तकिए लगाते हो?
So there are 2-3 points. One is you have to ask about the breathlessness. सांस फूलती है, आंसर में कम yes. लेटने पर सांस फूलती है, आंसर में कम yes. That is not orthopnea. Many students stop here. जब आप लेटते हो तो सांस फूलती है, patient said yes. It may be possible that the breathlessness is there while the patient is on standing, while the patient is on sitting, patient is on in the lying down position. Orthopnea is not that. Orthopnea is that breathlessness while the patient is on lying down, and the breathlessness relieved either completely or partially when the patient is in sitting position. All right?
Okay, sir.
Because, for example, if a patient is having a bronchial asthma, then the patient may also have a breathlessness while the patient is in sitting position, while the patient is on lying down. मतलब उसे लिटा लो, बिठा लो, खड़ा कर लो, सांस फूलेगा उसका. But that is not orthopnea. The orthopnea is when the patient is in a lying down position, feels breathlessness, but that breathlessness improves. Lot of noise from your side. Lot of
So is it
noise.
clear now?
It is clear, but in between there is a lot of noise. Okay, so that is that you have to ask about the orthopnea. Okay, and you have to include it in the history. You have included it in the history, but with a very brief point. These 2 points need some elaboration,
Okay.
because these are the 2 very important points. Okay, go ahead.
She also complained of occasional cough for last 2 months, which is associated with episodes of breathlessness. The cough is productive in nature with scanty, frothy, white, odorless sputum. No history of seasonal or diurnal variation.
So the cough is productive in nature
Yes,
with scanty, frothy, white, odorless sputum. At
yes, sir.
what time of day or night the sputum comes? No diurnal variation, no seasonal variation.
Yes.
Okay, and what about the position? Is there any posture in which the sputum is more?
Okay, sir. I haven't asked for that.
So that is one point you have to ask. So in which condition the expectoration is more in certain posture? In bronchiectasis,
Sorry, sir.
the and some cases of lung abscesses, the expectoration may be occur in some specific postures. Okay,
Okay.
okay, go ahead.
Throughout the course of illness, there is no history of chest pain, palpitations, fever, night sweats, evening rise of temperature, joint pain, weight loss, diminution of vision, swelling on leg or back, yellowish discoloration of eyes or skin, loss of consciousness, abdominal pain, decreased urine output or blood in urine, flushing or diarrhea, hoarseness of voice or difficulty in swallowing.
Why you want to ask about the yellow discoloration of eye and skin?
Sir,
What is the
if
significance
there is
there?
Sir, if it is mainly to gauge the progression or the complication due to the said disease, it might cause right ventricular failure and may lead to congestive congestive hepatomegaly and yellowish discoloration, jaundice, yellowish discoloration of eyes or skin.
And what about the joint pain? What is the significance of
The
joint
joint
pain?
So one of the DDs of the one of the DDs of our case might be either rheumatic heart disease or infective endocarditis, both of which can present with can have a history of joint pain.
Infective endocarditis.
Yes.
Infective endocarditis present like a joint pain.
So sir, more commonly it will present with fever and unexplained fever with and it might have some of the features, some of different features, some relating to the immunological component or and some relating to the vasculitis component. But the most common presentation is fever, which I have asked before the joint pain.
So if the patient is having infective endocarditis, then there must be some valvular heart disease prior to that. Normal
Yes, sir.
valve में तो होगा नहीं infective endocarditis until unless it is SLE or something else. All right. If it is rheumatic, then valvular heart disease should be there. So what is the relation of the joint pain with that valvular heart disease? Is there any significance with the joint pain?
So
आपको
regarding the
joint
infective
pain की history
endocarditis.
no, the valvular heart disease, the case which you are presenting.
Sir, the said case could also be a result of Liebman-Sachs endocarditis also. So in which the patient might again have joint pain.
Okay. Would you like to ask any other question regarding that joint pain
Sir,
to the patient?
mainly if we are suspecting a past history of ARF, we would be asking whether it was a major joint involvement like knee joint, and
So
if
you
it
have to
was
ask
it was showing a.
you have to ask that question in the past history. You have asked in the past history.
Yes, sir, I have also asked in the past history, but I have not specified because the patient denied any history of joint pain. I did not ask further
Hmm.
about the characteristic of the pain. The patient,
See,
which is
see what happened. See what happens with the history of rheumatic fever. Okay, what happened with the history of rheumatic fever? That
the
the patient at that time you are presenting the case. The patient is 30 years of age, but
yes,
joint pain might come when the patient was 12 or 13 or 14. That means it was good 14-15 years back. So there is a possibility that the patient does not remember, does not recall that the patient might have a joint pain. Some joint pain may occur, some amount of fever is there, some amount of palpitation is there, which patient may not aware, patient may not be able to recall. So that is the point which we have to poke in. You have to ask many time. Kabhi nahi hua, kabhi nahi hua. Why? Because it is important for us to make that there must be a history of joint pain that will make our case strong. If there is a history of rheumatic fever, हमारा केस जिस चीज
yes.
से इम्प्रूव बढ़ रहा है, अच्छा आ रहा है आगे, वो पॉइंट्स हमें 2 बार 3 बार जरूर पूछने चाहिए.
Okay,
ओके, चलो,
okay.
गो अहेड.
Sir, I had a doubt in the negative history section.
टेल मी.
Sir, can a patient of congenital heart disease, for example, TOF, present very late, like in the 20s? And if yes, then how will we differentiate it? Well, I wanted to include a point of another point in that I have written in gray. That's if the patient experienced any spells of bluish discoloration of face and lips, which would be, or have any history of that would be relieved on squatting. But I'm not sure how relevant it is in
See,
actual
no,
practice.
there is no point of asking these type of question in this case. Why? Number one, the presentation is very late in this case. The first symptom occur at the age of 30 years. In valvular heart disease, usually these are the congenital, not in the valvular, the congenital heart disease. The patient present at the time of birth or more तो 1 year, 2 year, 3 years, 4 years तक patient history दे देता है. So if the first symptom itself comes at the age of 30 years, then the valvular heart disease, the congenital heart disease is very unlikely. Number one. Number two, bluish discoloration is the most important thing with which the patient present. It is not the breathlessness, it is the bluish discoloration most of the time. And that is true in the early ages, at the age of 2 years or 3 years. But if the first symptoms arise at the age of 30 years, then congenital heart disease is very unlikely.
Okay, sir. Shall I move into the past history?
Okay.
So, in past history, there is no history of childhood fever with sore throat, joint pain, skin manifestations, or abnormal movements. Patient is not a known case of diabetes, hypertension, or asthma. There is no history of TB, no similar episodes in the past, or no history of any surgery, no history of dental extraction.
Why there is a history of dental extraction important?
Sir, if the history of dental extraction is important in cases of infective endocarditis, but this patient does not have a history of surgery or use of any prosthetic valves, it becomes a little less important here, unless it is a naive valve endocarditis.
Oh, go ahead.
Drug history: patient is presently not on any medication or supplements, no history of monthly injections or tablets in the past. Patient is having regular menstrual cycles with normal blood loss during each cycle. No history of recent amenorrhea or pregnancy. Obstetric history: G2P2L2A0. She has two children, both girls who are 7 years and 5 years old. Patient didn't receive ANC for either delivery, and both pregnancies were delivered at home. No history of similar complaint in either pregnancies. Both children are alive and healthy.
That is again very unusual point. Most of the patients, especially the females, may have symptoms during the childbirth, especially the valvular heart disease. It is very unlikely that the patient gives two issues are there, na? Two children. Patient is having two children, so
Yes,
two
sir.
pregnancies are there without any episodes of breathlessness, because breathlessness is the most common complaint in the valvular heart disease suffering with when the patient is having the pregnancy.
So regarding
Okay.
this, when I was making the case, I was thinking that because maybe the last pregnancy was 5 years old, maybe the stenosis was not that severe, and also the patient was delivered. She didn't receive any in antenatal care. So if she had some mild breathlessness, she might have ignored it. If she had gone for an regular antenatal
That is
care,
the
then it might have been.
that is what I want to emphasize on, that under the normal circumstances means when the patient is normal, non-pregnant female, mild symptoms may not be present in those type of patients. If mild symptoms are present, then also patient may not experience. But during the labor or during the pregnancy or in the pregnant state, the patient, most of the patient present with some kind of symptoms. If they have a minute of valvular heart disease. In fact, many patients comes during the pregnancy that they have experienced these type of symptoms, and prior to that there is no history, and when we examine the patient, when we do the echocardiography, the patient turned out to be of valvular heart disease. Okay. Okay, go ahead.
So socioeconomic history: she belongs to a low socioeconomic family according to the modified Kuppuswamy scale, lives in urban slum with overcrowding.
Okay.
Family history: patient has four sisters. All of her siblings, including her parents, are alive and never had any similar complaints. No history of any sudden unexpected death at a young age. Personal history: patient has an average Indian diet with adequate sleep. There is no history of smoking or use of any recreational drugs. No history of alcohol intake. Normal bowel bladder habits. So that is all with history. Hello, sir.
Go
Excuse
ahead.
me, sir. Yes. So now Kshitij Malhotra will be taking over. He will be discussing
Wait, wait,
examination.
wait, 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 wait,
Yes.
wait, wait.
Okay.
So at the end of the history, what are your differential diagnosis? Or summarize your history.
Sir, my patient is a So my patient is a 30-year-old female presenting with gradual progressive shortness of breath for 1 year with frothy sputum for 2 months. She initially had NYHA class 1 symptoms which progressed to NYHA class 3 over last 1 year. She has history of PND but no orthopnea. There is no history of palpitations or chest pain. So uh, uh, she's most in my differential diagnosis on topmost. I would like to keep a case of valvular heart diseases.
Why valvular heart disease? What are the points in
So,
favor of valvular heart disease, or what are the points against the valvular heart disease?
so when I started with the chief complaints and the first part of HOPI before the negative history, I had a set of diagnosis in my mind. One was, for example, valvular heart disease, and in that infective endocarditis, RHD, etc. Then in the myocardium.
Bache,
Yes, sir.
the differential diagnosis should be made on basis of some points. So what are those points by which you come to the conclusion that it may be a valvular heart disease?
So first of all, the age is in favor of a RHD, the age of presentation. Then
30 years की
the
एज में 30 years की एज में कार्डियोमायोपैथी भी हो सकता है,
yes, a
especially
cardiomyopathies
after
can
giving
also
that.
be there.
No,
Yes, sir.
cardiomyopathy
So
is also
there is
there,
possibility.
but what are the points which are in favor of valvular heart disease?
Sir, like dilated cardiomyopathy could also have been a cause, but in history we have seen that dilated cardiomyopathy first of all presents more commonly as acute heart failure rather than uh, chronic heart such chronic progression. Also, in the history there is no risk factor or a suggestive cause that can suggest regarding dilated cardiomyopathy.
I'm not talking about dilated cardiomyopathy. I'm talking about cardiomyopathy. So there are many types of cardiomyopathy. My basic question, my first question was still there. What are the points with which you come to the conclusion that the patient is having the valvular heart disease? There must be some points. So tell me those points. भैया आपने कहा पेशेंट को valvular heart disease है, तो कुछ पॉइंट्स होंगे ना आपके पास में जिसके बेसिस पर आप कह रहे होगे ओके पॉइंट नंबर 1, पॉइंट नंबर 2, पॉइंट नंबर 3, इसलिए ये valvular heart disease है एंड देयर आर सर्टेन पॉइंट ये हो सकता है valvular heart disease ना हो.
So, so mainly because of the PN, the major significant positive history in the patient is PND and the progressive breathlessness, especially on exertion. But
Krishnashish, first
yes, sir.
you have to differentiate. First you have to see what is the origin of the disease. See, there are two things. What is the lesion and where is the lesion? Okay. Whenever you take a history and you do the examination, you present the history, you see the patient, then there you ask two questions to yourself. What is the lesion and where is the lesion? Okay.
Yes.
So when you see what is the lesion and where is the lesion, what is the first thing? What is the first question you have to answer? What is the lesion or where is the lesion?
So what is the lesion?
If you
Where is
if
the
you
lesion
if you
system?
if you if you if you go ahead with the what is the lesion, then in the whole body there are n number of systems and you will be nowhere if you go straight away with the what is the lesion. First you have to identify where is the lesion. Okay, in that case what history you have present, where is the most probability that the lesion belongs to? कहाँ पर होगा lesion?
So most likely it is a cardiovascular. It is a lesion of the cardiovascular system.
Why?
So because of the history of PND is positive.
Okay.
And so,
Good.
also,
Good.
sir, so if we see from the beginning, a gradual progressive shortness of breath can have three major DDs, major systems. One is cardiovascular, respiratory, or hematological anemia. Again, history of PND, a
It is
history
not.
of
Wait. It is not hematological. It is cardiovascular. It is respiratory, and it is non-cardiorespiratory. Okay.
Okay.
It may be non-cardiorespiratory. For example, if I am talking about the beriberi, it is non-cardiorespiratory. It is not hematological disease or a Paget disease. But all these diseases may mimic the valvular heart disease. So, okay, you are right. We have to divide the patient into a cardiac disease, respiratory disease, and non-cardiorespiratory disease. Okay, go ahead. What you want to say?
So again, regarding between these three, a history of PND, a history of cough after a long time of breathlessness, and in this case there is no orthopnea, but a cause of orthopnea with and a history without any diurnal variation, without any major history of cough. Again, and at this particular age takes it a little towards cardiovascular system.
So first you have to differentiate between the breathlessness, as the breathlessness is that major complaint in this case. It is
Yes.
one of the chief complaint. In fact, it is the only complaint with which patient present to you. So
Yes.
whether we have to ask this question, whether the breathlessness is of the cardiac origin or is it of the respiratory origin. There are some points which are in favor that it is of the cardiac origin. What are those points?
So the history of paroxysmal nocturnal dyspnea.
Okay. Or
Sir, shortness of breath on exertion and relieving on rest can it supports
can be,
cardiovascular system, but it can be in either cases.
it can be in either cases, but the way patient has presented means over a period of 2 years, it is gradually progressive. Usually, respiratory disease does not have that much of progression. Along with that, if they have a breathlessness of that much duration, then the sputum is the major symptom.
Yes, sir.
Okay, so these 2 points, orthopnea and PND, are the most important history which differentiate whether the patient is of the breathlessness of the cardiac origin or it is of the respiratory origin. Okay, so once you establish that the breathlessness of the cardiac origin, then all the differential diagnosis of the respiratory origin automatically eliminates.
Yes.
Yes or no?
Yes, sir.
Then come to the cardiovascular diseases. What are the differential diagnoses? When you consider any differential diagnosis, for example, the valvular heart disease, the cardiomyopathies, that is a major differential diagnosis which you kept. So you should keep 2-3 points in favor, or if there any point or 1 point or 2 point which is against that your differential diagnosis, you should speak it out. Okay.
So actually, in my case, I was unable to find a particular positive point. Rather than I have made multiple negative points. I have tried to clean the diagnosis by the method of elimination.
No. See, you can eliminate n number of diseases, but there must be, आप ये कह सकते हो ना, ये disease ये नहीं है, ये नहीं है, ये नहीं है, ये नहीं है, ये नहीं है. That is all right. But what it is, हमें पेशेंट को ये नहीं बताना भाई आपको एनीमिया नहीं है, आपको कार्डियोमायोपैथी नहीं है, आपको एस्थमा नहीं है, आपको सीओपीडी नहीं है. पेशेंट कहेगा वो तो सब ठीक है, पर डॉक्टर साहब मुझे है क्या? Is it?
Yes.
Yes, yes or no?
Yes,
भाई
sir.
आप इलाज किसका करोगे? आप किस डिजीज का इलाज करोगे? आप डिजीज का ट्रीटमेंट करते वक्त ये थोड़ी देखोगे कि इसको ये नहीं है, ये नहीं है, ये नहीं, ये नहीं. Those are the points which help you in making the certain diagnosis. But there has to be some differential diagnosis or some positive findings which suggest that the patient is suffering from this disease. All right.
Yes.
So, like in this case, if you want to make it valvular heart disease, there are certain points like a gradually progressive breathlessness, which is gradually increasing. That is of the increase in the symptoms from NYHA class 1 to NYHA class 3 over a period of certain time. Then there is a history of PND. It would be better if there is a history of orthopnea. Okay. And what type of medication improves the symptoms? That is also important. जब आपने क्वेश्चन पूछा पेशेंट से, आपको सिम्टम आ रहे हैं, पीएनडी हो रहा है, जब आप पीएनडी की जगह पूछ रहे थे या ड्रग हिस्ट्री में पूछ रहे थे, वहां पर बहुत इंपॉर्टेंट है कि क्या मेडिसिन लेने से आपको इंप्रूवमेंट होता है. पेशेंट में से जब मैं इनहेलर लेता हूं तो मुझे इंप्रूवमेंट होता है. दैट मीन इट कांट बी वेल्वुलर हार्ट डिजीज. ऑलराइट, देन इट मे बी a respiratory disease. If patient said I took some oxygenation, then the symptoms relieve, then there is a possibility that the patient may have a respiratory disease. If the patient said some tablet is there, then you can ask, जब वो tablet लेते हैं उसके बाद में यूरिन ज्यादा भी आता है क्या आपको? The patient में से हाँ जी डॉक्टर साहब आता तो है. That means the patient is taking the diuretics. And if the symptom improve while taking the diuretics, that means there is something which is related to cardiac lesion. So indirectly, you have to see all these points. You have to incorporate or inculcate all these points also. Okay.
Okay.
Many times after the history, many examiner ask these two things. The summary, you have made a summary, but the summary is of the after the history and the examination both.
Examination.
Okay, but many examiner insist on presenting the summary after the history itself and differential diagnosis after the completion of the history. So make sure that you made some points, made some differential diagnosis after the history also. Okay.
Okay.
Okay. So who will be going to present the general physical and the systemic examination?
So Kshitij Malhotra will be presenting. He will be presenting from the same device.
Kshitij. Kshitij?
Yes, sir. Good morning, sir.
Good morning, Kshitij. So present your finding.
Examination. The patient is conscious and well oriented to time, place, and person. Consent was taken. She is sitting comfortably in the bed, and then height is 155 centimeters, weight is 52 kgs, BMI is 21.6. Vitals in pulse. The pulse was measured in the radial artery. The rate was 82 per minute. Rhythm regular. Volume normal. Vessel wall non-palpable. Character no such special character appreciated. Radio-radial and radio-femoral delay was not seen. The peripheral pulses were palpable.
See, when you presenting any Kshitij, whenever you present
Yes, sir.
any finding, you don't have to present it in a point-wise manner. You can write it in a point-wise, whatever you want or whatever way you want to write it. But whenever you present in a case, you should not present like in a point-wise manner. It should be like my patient pulse rate is 82 beats per minute. It is regular in rhythm and the volume is normal. Okay. ऐसे नहीं rhythm regular, volume normal, rate 82, vessel wall non-palpable. It should be in some type of a sentences. Okay.
Okay, sir.
Okay. There was no radial and radiofemoral delay. You said the volume is normal.
Yes, sir.
How come a volume is normal? How you come to the conclusion that the volume is normal?
Sir, by sir, since the Pulse pressure is normal then.
Pulse pressure. What is pulse pressure?
SBP minus systolic blood pressure minus diastolic blood pressure.
How much it is?
Sir, it is 110 systolic blood pressure and 70 diastolic
No.
blood pressure. mmHg.
No. The pulse pressure. Normal pulse pressure. How much is the normal pulse pressure?
So, 40 to 60 mm of Hg.
40 to 60 mm. Are you sure? Pulse pressure.
No, sir, 30 to 60 mmHg.
Are you sure again?
No, sir.
कितना होता है?
Sir, not sure.
Not sure? Okay. पढ़ो इसको.
Okay, sir.
कृष्णाशीष बताएगा कितना पल्स प्रेशर होता है? Or anyone can write it in a chat box. No question is asked by any student in the chat box. सो रहे हैं सब. चलो बताओ आगे.
So the blood pressure was 110 by 70 mm of Hg, measured in left brachial artery in supine position. It is consistent in other three limbs. The temperature was 98.6 degrees Fahrenheit in left axilla. Respiratory rate, it was 20 times per minute. Thoracoabdominal, use of accessory muscles not prominent. And so neck veins are not engorged. Jugular venous pressure is normal. It is 3 centimeter rise above sternal angle at 45 degrees inclination.
So what is the implication or if the patient is having the engorged vein?
Sir, if there is an engorged vein, then we have to suspect that then the patient is going into failure.
Okay, good. What else you can see?
Sir?
What else you can see in the neck veins? One is the engorgement. You see that the neck veins are engorged. Then
Sir,
what else you can
carotid
see?
druid.
In the vein.
Pulsations.
What?
Vein. Pulsation in the vein.
Pulsation. Very good. Pulsations in the vein. So what type of pulsations are there in the vein?
Sorry, sir. Yes.
So the another question is, I should refrain my question. How will you differentiate whether this is the jugular venous pressure you are seeing means jugular vein or it is a carotid artery?
Sir, by incline postural changes, when we incline the patient, there is shift in if the pulsation is due to vein. Excuse me, sir. Sir. Sir.
Am I audible now?
Yes, sir, you are audible now.
There was an internet problem. Internet was not there. Okay, go ahead. So my question was, how will you differentiate whether whatever you are seeing is a carotid artery or the jugular venous?
Sir, first of all,
जुगलर
the
जुगलर
carotid art.
जुगलर हाँ जुगलर vein और carotid artery में कैसे differentiate करोगे?
Sir, first of all, jugular vein will be superficially palpated and carotid artery will be deeply palpated. And then we can check for hepatojugular reflux, in which if we put a slight palm at the umbilicus, the veins will drain, but that would not be the case with this.
क्षितिज बिना पढ़े बता ना अपने आप, एग्जाम के अंदर बुक नहीं खुली होगी.
नहीं सर, खुद से ही बता रहा हूँ.
अगर आप खुद से बताते तो यू सेड यू पुट द प्रेशर, नॉट कीप द पाम. ये बुक में लिखा होता है कीप द पाम.
सर मतलब मैंने ऐसे पढ़ा था कल कि पाम अम्बिलिकस के साइड पे रखते हैं.
अम्बिलिकस के साइड पे नहीं रखते बच्चे. हिपैटोजुगुलर रिफ्लेक्स देख रहे हो ना आप?
यस सर.
तो हिपैटोजुगुलर रिफ्लेक्स के अंदर क्या देखते हैं? You put the pressure on the lower level of the liver, lower part of the liver, and because of that pressure, the jugular venous pressure जो है वो थोड़ा सा rise हो जाएगा. The GVP will rise to some point. That is called as the hepatojugular reflex. Liver involved है, hepato and jugular vein. Okay, that is the one point. The other points are, number one, the jugular vein has predominantly inward movement. ठीक है, जो वेन्स होती है उसका प्रीडोमिनेंटली इनवर्ड मूवमेंट होता है. जो आर्टरी होती है कैरोटिड आर्टरी, बिकॉज देयर इज अ लॉट ऑफ प्रेशर इज देयर, सो द प्रीडोमिनेंट मूवमेंट इज द आउटवर्ड मूवमेंट. ओके,
यस सर.
अनदर पॉइंट इज दैट यू कैन नॉट गेट अबव द, यू कैन नॉट हैव अ डेफिनेट पॉइंट इन केस ऑफ अ आर्टरी, क्योंकि आर्टरी तो फिर ऊपर तक जा रही है.
यस सर, पर वेन में हमें आपको डेफिनेट पॉइंट मिलेगा. यस सर,
बट वेन में आपको डेफिनेट पॉइंट मिलेगा. ओके,
यस.
ठीक है. Another important point is the position. The carotid artery is palpable just inside the internal your sternocleidomastoid. It is inside the sternocleidomastoid, while the vein is outside the sternocleidomastoid. It is lateral to the sternocleidomastoid. Okay. Okay. Shall go ahead.
So moving to the general physical examination, patient is lying comfortably on the bed. Body build is average. Patient has dark complexion with black hair. No pallor, icterus, cyanosis, conjunctival hemorrhage. Then sir, we are not saying there is no corneal arcus or xanthelismata, but it is mainly asked in ischemic heart disease. Should we ask it here?
You can see these are the examination points. Patient will not tell you whether the arcus is there or not. You have to examine. When you examine the eyes and you are looking for the arcus, if arcus is there, say there is arcus. If arcus is not there, you may say there is no arcus. Okay,
Sir,
but make sure
should we mention it?
See, if you want that the question is to be asked on the arcus, then you should tell the examiner. क्योंकि जैसे आप बोलोगे आर्कस है, ज़ेंथलिज्मा है या ज़ेंथलिज्मा नहीं है, आर्कस नहीं है, एग्जामिनर पूछेगा आर्कस क्या होता है, ज़ेंथलिज्मा क्या होता है, तो आप उस पर क्वेश्चनिंग चाहते हो या नहीं है. इसे बोलते हैं एग्जाम वाइवा को अपनी तरीके से चलाना. ओके, यू deliberately put some points forward so that examiner may ask only those points. अगर आपको आर्कस के ऊपर अच्छे से आता है, आप चाहते हो आर्कस के ऊपर क्वेश्चन हो, आप उसको मेंशन करो आर्कस. एग्जामिनर अपने आप पूछेगा आर्कस क्या होता है भाई, अच्छा आप बता दो. ज़ेंथलिज्मा क्या होता है, ज़ेंथलिज्मा बता दो. बट इफ यू डोंट नो एनीथिंग अबाउट द आर्कस, एनीथिंग अबाउट द ज़ेंथलिज्मा, so don't tell it.
Okay.
Okay.
Yes.
What is the significance of conjunctival hemorrhage here?
So conjunctival hemorrhage, first of all, if it can be present in hypertension, and also it can be there in bacterial endocarditis.
So in this case, the patient blood pressure is normal. Patient is not in
Yes,
any
sir.
antihypertensive medication. So hypertension is
Yes,
out.
sir.
So what is the
Yes, sir.
significance of conjunctival hemorrhage in this case?
Sir, just to rule out the infective endocarditis, no significance in this case.
Infective endocarditis. So what will you get in the infective endocarditis in conjunctiva?
Sorry, sir. मतलब conjunctival hemorrhage होती है
हाँ बेटा, उसको क्या बोलते हैं, कैसे डिस्क्राइब करते हैं?
फंडस पे तो रॉड स्पॉट्स होते हैं, मतलब
फंडस इज ऑल राइट. कंजक्टिवल हेमरेज कैसे आप डिस्क्राइब करोगे? नाम तो नहीं होता उनका कुछ, बट आप उसको डिस्क्राइब कैसे करोगे? व्हाट टाइप ऑफ लीजन्स आर दो?
वो सर ये वाले आर्बरस मतलब type.
Okay, what about that skeletal deformity of the limbs? What is the significance of skeletal abnormalities in this case?
It is to rule out Marfan syndrome, Turner syndrome.
So what are the what are the deformities in the Marfan syndrome? Skeletal deformities.
So Marfan's में there are tall limbs, then there is polydactyly, and there is hyper-extensible joints.
Good.
And also, sir, we have to rule out the kyphoscoliosis in skeletal abnormality, so that we can rule out that apex beat is not shifted due to that.
What is the significance of this xanthoma? Last you have you have written
it
no
is again for to rule out dyslipidemia.
तो आप xanthoma पूछ रहे हो, आप xanthelisma नहीं पूछ रहे हो?
नहीं सर, वो साथ ही था वो पीपीटी में, तो नीचे चला.
Okay, no problem, no problem. So there is no xanthelisma, no xanthoma, no pedal edema, no sacral edema, and patient has a poor oral hygiene, but no sign of vitamin deficiency. Now this is a very tricky line. आपने लिख तो दिया ऐसे ही, but whole vitamin deficiencies can be discussed here. You have written it, no signs of vitamin deficiency. So what are the various signs with which patient present to you with a vitamin A deficiency, let's say? ऐसा होता है ना आपने. Yes, good.
Bite out spots in the eye.
And what is the main symptom? That is a finding.
It's a night blindness.
That is night blindness. So you should also prepare with the that what are the signs of the various signs of the vitamin deficiencies.
Yes, sir.
Okay, go ahead.
No pedal or sacral edema, no xanthomata.
What is the significance of the sacral edema? Pedal edema is all right. What is the significance of this sacral edema?
Sir, it is edema when the patient.
When the patient.
Sir, supine position में अगर वो ज़्यादा टाइम तक लेटा रहेगा, तब मतलब उससे पता चलेगा कि मोबाइल नहीं है पेशेंट.
Yeah, correct. So the edema comes in the dependent part. So that depends what is the posture of the patient. If the patient is in a sitting position or the patient is in the moving position, means patient is on standing position, then the most commonly the pedal edema is there. And if the patient is in lying down position, then the edema is in the sacral area. So you should always check for the sacral region also for the presence of edema. Many times only pedal edema is seen, है ना, ज्यादातर स्टूडेंट्स सिर्फ पीडियल एडिमा देख के छोड़ देते हैं. ऑलवेज लुक फॉर द सेक्रल एडिमा. गुड, गो अहेड.
Okay. And so moving to the systemic examination, cardiovascular examination. On inspection, we are seeing a bilaterally symmetrical chest with no deformity of precordia. Apical impulse seen in left fifth intercostal area, just medial to mid-clavicular line. No visible pulsation, prominent vein or bulge. No scar mark or bony deformity. Then or palpation. Apex beat is palpable in left fifth intercostal area, just medial to mid clavicular line, tapping in nature. Diastolic thrill is palpable in mitral area, better in left lateral position and in full expiration. Absent parasternal heave.
Wait. So apex beat is palpable in the left fifth intercostal area. Is it normal or abnormal?
It is abnormal. It means that loud as well. No, sir.
Think before
Sir,
you
it
speak.
means that there is loud. It means that there is loud S1.
No, 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 no. Listen, I am only talking about the apex beat palpable in left fifth intercostal space.
Sir, that
That
is
means
normal.
I am.
Tapping in
That
nature.
means अभी तो बेटा मैं टैपिंग पर आया नहीं. I am only asked about the site of the apex beat, which you tell me
That
the
is a
about
normal.
the. So apex beat in left fifth intercostal space, is it normal or abnormal?
That is normal.
That is normal. So what is the normal apex beat? What is the site of a normal apex beat?
So in left intercostal space, just medium to mid clavicle.
Mid clavicular line. So until that point, the apex beat is normal. The second point is
Yes, sir.
it is tapping in nature. So what do you
Tapping.
mean by
Yes,
the
sir.
tapping in nature? What do you mean
Sir,
by tapping in nature?
Sir, that when we have placed our this top pulp of finger, and on that it like taps.
आप पहले से ही बता
It
रहे थे
comes
बच्चे,
and goes.
तो ये नहीं, हाँ ये नहीं है इसका, जो आप पहले बता रहे थे वो सही है.
Loud S1, sir.
Yes, tapping apex means loud first hard sound. Means
Yes, sir.
what it means? Tapping means ये जो हम आपको बता रहे हैं ना, just come and go, ये तो समझाने के लिए होता है. कई कई लोग आपको बताते होंगे टक 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 ऐसी आवाज आएगी, बट ऐसे टक 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 आवाज थोड़ी आती है. Yes or no?
Yes, sir.
Tapping apex means palpable first hard sound. I am underlining this, palpable. Normally, I am not talking about the auscultation. I am talking about the palpable. Normally, the first hard sound S1 is not palpable. Again, auscultation नहीं बोल रहा हूं मैं, palpable. जब आप palpate करते हैं तो first hard sound palpable नहीं होती है. Make it clear. Normally. अब आप first hard sound कैसे identify करेंगे?
Sir, first I will place my thumb on the common carotid artery, and then I will palpate it along with this palpation, and if they are both matching, then it is S1, first heart sound. Corroborating, then it is first heart sound.
So first heart sound normally not palpable. Okay.
Yes,
it is auscultation में आपको पता लगेगा first heart sound second heart, but normally first heart sound palpable नहीं होती है. अगर वो palpable हो रही है, if it is palpable, then it is called as the tapping apex beat. Make it clear. Mitral stenosis का केस सबसे ज्यादा आता है और सबसे ज्यादा क्वेश्चन यही पूछा जाता है, tapping apex. What do you mean by tapping apex? Is it clear?
yes.
Okay. Another point is, what are the other different type of apex beat, nature of apex beat? One is the tapping, other are the,
So there is
we
a
have discussed,
flush.
we have discussed all these points in the previous class also. Just name it. What are the
Yes, sir.
other different type of apex beat?
So there is a normal, then there is a heaving, then there is hyperkinetic, and then there is tapping.
Hmm. So heaving, hyperdynamic, and tapping.
Tapping.
I hope all the students know the difference between the tapping, heaving, and hyperdynamic. No need to repeat again this point. If someone has any query, someone has any problem, then you can write it down. Next point about, okay.
Sir, your voice is
Diastolic thrill
breaking.
is palpable. What do you mean by this diastolic thrill? My voice is breaking. All
Sir,
right.
sir, now it is right. All right. Sir, the diastolic thrill is
Is it all
palpable
right?
in mitral area. Yes, sir.
Okay. So this, hmm. Go
So,
ahead.
sir, it is going when it is coming in breaks.
Okay. I think there is some internet issue. Go ahead. You go ahead.
Okay, okay. Sir, diastolic thrill is palpable. It means that there has to be a murmur on auscultation, and there is, since diastolic thrill, then there has to be a mid-diastolic murmur in mitral area, because only in
बच्चे देख,
whenever
देखो
the
सुनो
thrill.
सुनो
Yes, sir.
सुनो सुनो, वेट क्षितिज,
Yes, sir.
देखो जब आप काउंटिंग बोलते हो ना, तो इट शुड बी लाइक 1 2 3 4 5, यस और नो.
Yes, sir. Yes, sir.
काउंटिंग 5 4 अगर बोलोगे ना तो फिर प्रॉब्लम होगा. यू आर ट्राइंग टू एक्सप्लेन द थिंग्स विद द थिंग्स विच हैज टू कम आफ्टरवर्ड. अभी तक आपके प्रेजेंटेशन में कहीं पर भी मरमर नहीं आया है,
No, sir.
यस और नो. तो हाउ कैन यू
No, sir.
एक्सप्लेन द थ्रिल ऑन द बेसिस ऑफ मरमर? ये तो आपको समझाने के लिए होता है कि ओके, अगर थ्रिल है दैट मीन्स मरमर हैज टू बी प्रेजेंट, बट यू कैन नॉट एक्सप्लेन द थ्रिल ऑन द बेसिस ऑफ मरमर. माय क्वेश्चन इज व्हाई देयर इज ए डायस्टोलिक थ्रिल. डायस्टोलिक थ्रिल आपको कैसे,
Sir, due to continuous pressure
डायस्टोलिक
gradient.
थ्रिल, नहीं डायस्टोलिक थ्रिल आपको कैसे अप्रिशिएट हुई? जब आपने पेशेंट को एग्जामिन किया, आपको कैसे पता लगा डायस्टोलिक थ्रिल है या नहीं है? सबसे पहले तो आपको ये पता लगेगा थ्रिल है या नहीं है, यस और नो.
Yes, sir.
देखो एग्जाम के अंदर एग्जामिनर यही पॉइंट देखता है कि आपने आपने बोला डायस्टोलिक थ्रिल, तो वो पूछेगा डायस्टोलिक थ्रिल कैसी दिख रही है भाई, आपको कैसे अप्रिशिएट हुआ? सबसे पहले तो आपको ये बताना पड़ेगा दैट देयर इज अ थ्रिल. जब आपको ये पता लग गया थ्रिल है, तब आप उसे गेज करोगे वेदर इट इज सिस्टोलिक थ्रिल और डायस्टोलिक थ्रिल. तो थ्रिल कैसे फील होगी आपको?
So, while palpating, blood gush करेगा.
ब्लड तो
Thrill
गश
सर हम
करेगा.
बेस ऑफ फिंगर से ले.
बेस से या फिंगर से?
बेस ऑफ फिंगर.
बेस ऑफ फिंगर, बेस ऑफ फिंगर से. डायस्टोलिक कैसे कहोगे?
सर डायस्टोलिक वैसे जैसे मतलब कैरोटिड आर्टरी की पल्स को फील करेंगे और उससे पहले आ रहा होगा थ्रिल, तो मतलब वो डायस्टोलिक है.
ठीक है. अब तक आपने कहीं पर भी स्टेथोस्कोप, टिल नाउ यू हैव नॉट यूजिंग द स्टेथोस्कोप, तो यू कैन नॉट से कि मरमर आ रहा है या फर्स्ट हार्ट साउंड पैल्पेबल है या फर्स्ट हार्ट साउंड लाउड है. ऑल दीज आर द फाइंडिंग्स ऑफ द ऑस्कल्टेटरी फाइंडिंग्स. लाउड है नहीं है आप, यार ये पीछे जो हो रहा है इसको रोको प्लीज. एपेक्स बीच की फाइंडिंग है,
Sir,
The
voice is
first
breaking again.
start sound loud means the auscultation ending, not the.
Sir, not able to hear.
Okay,
Voice is breaking.
is it audible? Am I audible?
Hello, sir.
सुनाई दे रहा है नहीं? Am I audible?
Sir, break. There are
Am
breaks
I
coming
audible?
in your voice. Yes, sir.
कोई नहीं, आप you go ahead.
Okay.
Okay,
Sir,
present. What next?
absent parasternal heap.
What is this parasternal heap?
Sir, it is the when we put the base of hand at just medial to the sternum, then from base of hand till the base of little finger, then we feel that the continuity has been breached. It is mainly due to right ventricular hypertrophy.
So parasternal heave implies to either the right ventricular enlargement or the left atrial enlargement, both.
Yes, yes, sir, left it.
Oh, okay. Okay, go ahead.
On auscultation, the cardiac rate is 82 beats per minute with no apex pulse deficit, mid-diastolic rumbling murmur with pre-systolic accentuation is heard using the bell of stethoscope, which is of grade 4, louder on expiration without any radiation, accentuated by leg raising, squatting, attenuated by standing and Valsalva maneuver. Then, sir, loud S1 is audible, S2 normal with no splits audible, opening snap heard just after S2.
Stage.
Yes, sir.
Point or how you come to the conclusion.
Sir, I'm not able to understand. The voice is breaking.
This is a diastolic murmur.
Sir, please, can you repeat?
Diastolic. You
Sir,
come to the
I'm not able to.
diastolic murmur. How
Sir,
murmur
you're
is
not. Sir,
diastolic.
there are a lot of breaks.
Hello, am I
Hey,
audible?
yes, sir. Yes, sir.
Kshitij, am I audible?
Yes, sir. Sir, sir, you're not audible. At
Hello,
yes, sir.
am I audible?
Yes, sir.
No, lot of break.
Yes, sir. There are a lot of breaks.
My question is, how will you come to the conclusion that there is a mid-diastolic murmur?
Yes, sir. I
Why
will
there is
come
a
to that
mid-diastolic murmur?
conclusion.
Points which you come to there is a mid-diastolic murmur. That is the point.
Sir, first
Why
of
there is
all,
a murmur? Wait. करो. Yes, go ahead.
yes, sir. I will palpate the carotid artery
Go ahead,
pulsation
Kshitij.
along with it. Yes, sir. I'm speaking. Then, I will be able to localize S1 and S2, and then if the murmur comes after the S2, then and midway, then
So
it is the mid
so
diastolic.
so so that means you have to comment on first heart sound first. S1 पर पहले कमेंट करोगे ना?
Yes, sir.
आपने मरमर पर क्यों कमेंट किया पहले? Murmur come later. It is the first
Sorry,
heart
sir.
sound. What is the nature of the first heart sound? Whether it is normal, it is loud, it is variable, it is soft. Then what is the nature of the second heart sound? Whether the A2 P2 are there, is there any split? Is there any reverse split? Is there any opening snap is there or not? Then the murmur comes. Okay.
Sorry, sir.
Okay. And not to say sorry, which I have to make. Otherwise, in the exam, what happened? कि आपने फर्स्ट हार्ट साउंड नहीं सुना, आपने सेकंड हार्ट साउंड नहीं सुना, आपने मरमर कैसे सुन लिया?
Yes.
So what is the first heart sound is like?
It's a love.
फर्स्ट हार्ट साउंड कैसा सुनाई दे रहा है?
It's a love.
लाउड. कैसे?
Loud.
Why? Again, how? ठीक है. First
Yes, sir.
heart sound is loud.
Yes, sir.
आपने कैसे कहा फर्स्ट हार्ट साउंड लाउड है? What are the points on which you come to the conclusion that the S1 is loud?
Sir, first of all, on palpation, there was tapping, and then first heart sound is uh, has normally more than it is heard more than S2 in comparison to S2.
Okay. So what are the differential diagnosis of first heart sound loud? S1 loud के क्या-क्या differential diagnosis होंगे?
So first of all, there is mitral stenosis, and then there can be a tricuspid stenosis.
ठीक है, good. Good. Mitral stenosis, tricuspid stenosis, other causes?
So can the short PR interval? No, sir.
Okay.
So tachycardia.
Tachycardia, good. Tachycardia. बहुत सारे बच्चे severe anemia, Paget disease,
Yes, sir. Severe
beriberi,
anemia.
all these can cause the first heart sound to be loud. Okay.
Yes, sir.
Okay. Then the next thing is the second heart sound. What is the nature of second heart sound?
Sir, it is dub.
It is
It is sir, it is of more duration than first heart sound.
ये देख बच्चे कुछ भी करना कार्डियोलॉजी में ये लब डब यूज टर्म यूज नहीं करना. ये 12th क्लास तक ही होता है बस. ये there is no sound in the heart which is called as lub dub. Okay, the examiner will be very offended if you use this term lub and dub. Don't use it. भूल जाओ उसको, ऐसा कुछ होता भी है. What is the nature of the second heart sound? S2 कैसा सुनाई देगा आपको mitral stenosis के पेशेंट्स में? वैसे तो हमें नहीं पता भी mitral stenosis का पेशेंट है. The problem is that you know that the patient is having the mitral stenosis, and then you are presenting like a mitral stenosis. It should be other way around, that these are the findings 1, 2, 3, 4, 5, and because these are the findings, that's why the patient is having the mitral stenosis or mitral regurgitation, whatever be the findings. Okay, what is the nature of the second heart sound? आपको कैसे सुनाई दिया second heart sound? You have written it S2 normal. Now, what do you mean by second heart sound normal? इसका क्या मतलब है?
So duration उसकी normal है.
Durations.
And so there is no split audible. That also means it is normal.
And what do you mean by split?
So normally
Split
there is a A to P2
normally
split.
there is a
Normally there is a on deep inspiration there is a A to P2 split. It comes due to the aortic valve closes before the pulmonary valve, as the pulmonary valve has more blood due to.
What is the meaning of split? Normally there is a split.
So split, it means that there is a very slight gap in the timing of closure of the aortic and pulmonary valves.
Good. Then comes the opening snap.
Yes.
What about the opening snap?
Sir, it is heard just after the S2. It is due to forceful opening of the mitral valve.
Opening of the
mitral valve. Yes, sir, since we are hearing it in the mitral.
Is it a systolic event or a diastolic event?
Diastolic event.
It is a diastolic event. Okay. Then come to the murmur. Explain it.
It is a mid-diastolic rumbling murmur with pre-systolic accentuation and is heard using the bell of stethoscope and is of grade 4, louder on expiration without any radiation, accentuated by leg raising, squatting, and attenuated by standing and Valsalva maneuver.
Now, what do you mean by this rumbling murmur? See, these are the fine points which the examiner may ask you. What do you mean by rumbling murmur?
So it means that it is a resonant like thunder.
And what is this pre-systolic accentuation?
A pre-systolic accentuation, it means that there is a just before systole there is a gush of blood.
Okay.
During that's a late emptying phase.
So what are the differential diagnosis of mid-diastolic murmur? If you heard a mid-diastolic murmur, then what are the differential diagnosis?
So the differential diagnosis of mid-diastolic murmur are first of all atrial myxoma, then ball valve thrombus, then Austin Flint murmur, then Caricou murmur.
Okay. So how will you differentiate these differential diagnosis from the mitral stenosis?
Sir, for atrial myxoma, there will be tumor block to the murmur, and same with ball valve thrombus, and then sir, the Austin Flint murmur, there will also be concomitant findings of severe aortic regurgitation.
नहीं बच्चे, मैं तो ये पूछ रहा हूँ जो मिड डायस्टोलिक मर्मर के आपने कॉजेज बताए हैं उनसे आप माइट्रल स्टेनोसिस को कैसे डिफरेंशिएट करोगे?
सर ओपनिंग स्नैप से कर मतलब क्योंकि वो सिर्फ एमएस में ही आएगा.
No. In mitral stenosis, mid-diastolic murmur is associated with the pre-systolic accentuation. Apart from this condition, in no other conditions this pre-systolic accentuation is present. Okay, yes. Pre-systolic accentuation only present in cases of mitral stenosis. The other causes which you mentioned in the previously, the causes of mid-diastolic murmur, उनके अंदर pre-systolic accentuation नहीं होता है. Okay.
Okay, sir.
Okay. Another thing is louder on expiration. Why it is louder on expiration?
Sir, it is louder on expiration as due to sudden when we expire the air, all the blood from pulmonary veins come to left side of heart, and there is a increased blood flow to the left side of heart.
Okay. Okay. That is all right. So what? Anything else you want to tell? Any
No, sir.
examination left? So
Sir,
what's
other system examination are not significant.
not significant? So we'll leave that. So what are your differential diagnosis at the end of the history and the examination?
So differential diagnosis at the end of the history and examination are the atrial myxoma, then valvular thrombus, then carcinoid syndrome.
बच्चे इसमें mitral stenosis तो कहीं बोला नहीं आपने?
Some mitral stenosis.
जब आप डिफरेंशियल डायग्नोसिस बोलते हैं सबसे पहले तो आपने वो बोलना है जो आपका मेन डायग्नोसिस है. Differential diagnosis doesn't mean there is a one main diagnosis and there are some other diagnoses. Differential diagnosis means the diagnosis which you are keep in your mind after presenting the history and the examination. So mitral stenosis is the first differential diagnosis. Then the other differential diagnosis are the carcinoid syndrome, atrial myxoma, valvular thrombus. Now you have written mitral stenosis of possible of rheumatic origin.
Yes, sir.
Okay. So what is the evidence of this rheumatic origin?
Sir, as such in our history, there is no evidence, but it is said that mitral stenosis is almost always due to a rheumatic origin.
That is all right. But did you find any finding in your history in the examination which is suggestive of the rheumatic origin?
No, sir.
No. Another thing is without much evidence of congestive heart failure. What do you mean by much evidence?
So that means there were no signs and symptoms.
No signs. No? So much evidence मत लिखो, सीधा लिखो ना, no evidence of congestive heart failure. Suppose if the patient is having the atrial fibrillation, what are the findings
Yes.
in this patient? अगर patient को
Sir,
atrial
there
fibrillation
is
भी होता, हाँ.
so on JVP there will be absent A wave, and then this is pulse will be increased, and then sir,
Good.
though there is no hypotension, but there can be hypotension, and others.
Okay.
And also, sir, that pre-systolic accentuation will not be there.
Okay. Good. What about the pulse? Pulse कैसी होगी?
Pulse, sir, that it will be irregular.
Irregularly. Good. So out of all these differential diagnoses, your diagnosis is mitral stenosis.
Yes,
Okay,
sir.
there are one point also there. No evidence of congestive heart failure or atrial fibrillation, and without any evidence of infective endocarditis, or with some evidence of infective endocarditis. Diagnosis में ये भी आना है.
Okay, sir.
Okay.
Okay.
Okay. So tell me some complications of mitral stenosis.
So complications are congestive heart failure, then atrial fibrillation, then this right right atrial enlargement, pulmonary hypertension, pulmonary capillary rupture, pulmonary venous hypertension, then right ventricular hypertrophy.
Pulmonary arterial hypertension. What are the signs of pulmonary arterial hypertension?
So the signs of pulmonary hypertension are cough, chest pain, breathlessness, And
What are the signs? What are the findings in the pulmonary arterial
signs,
hypertension?
sir, signs, there will be diffi so, sir,
Hmm.
parasternal heaving will be there.
Okay. Anything else?
So then there will be paradoxical split, wide and split.
अब ये क्या होता है?
So in that the closure of the pulmonary valve will take a longer duration to close
Hmm.
than the aortic valve.
Okay. So how will you investigate this case?
So for investigations, my first line investigation would be chest X-ray, but my definitive investigation would be an echocardiography. And also
Okay.
we can find some changes on ECG also.
What are the findings on the echocardiography?
So on echocardiography, the mitral valve area will be lessened. That so normally it is 4 to 6 centimeters square, but it would be less than 2.5 centimeters square in this case, because then only it becomes symptomatic.
Mm-hmm.
And then, sir, if there is if the patient is progressing to heart failure, then there will be reduced ejection fraction, because in this case there is reduced ejection fraction heart failure.
Okay.
And then, sir, on echo we can also appreciate left atrial enlargement.
Left atrial?
Enlargement.
Okay.
So, sir, sir, you are not audible.
Am I audible?
Yes, sir, you are audible.
Okay. Anything else you want to ask?
No, sir. Sir, sir, you are not audible.
Hello.
Yes, sir.
Am
Yes,
I
you
audible
are
now?
audible, sir. Yes, sir.
Okay. There is a lot of network issue here. So anything else you want to ask me?
No, sir. Thank you,
No,
sir.
everything is clear.
No, no, sir, not like that.
Okay. Anything else, Krishna Asish, you want to ask me?
So I will give it to Krishna.
So I can answer one
No,
or two
sir.
questions which the student has asked me in the chat box. First question is, can we appreciate whether murmur is rumbling or not? Yes, we can appreciate that the murmur is rumbling or not. Rumbling simply means it's roaring. It depends on the what is the condition of the valve. See, many times the student, am I audible?
Yes, sir.
Okay. Many times the student make a mistake that they see if the patient is having the mitral stenosis, then they write rumbling murmur or S1 is loud. It is not the case. See, any murmur or any findings in any of the valvular heart disease is occur because of the condition of that valve. Suppose if the valve is calcified, okay, if the valve is calcified, then first heart sound will not be loud. So in not every case of mitral stenosis, first sound is loud. First sound is loud only if the walls are pliable. Means कोई calcification नहीं है, कोई उनके अंदर thrombus नहीं जम है, ठीक है? So if the valve is pliable, the valve is moved freely without the calcification, then the findings are different. And again, the murmur depends on the size of the opening. If the opening is very small, then the murmur is very harsh. Okay, so yes, you can write it, you can say the murmur is rumbling, but not in every case, not in the every case of mitral stenosis. Another question is, why does pre-systolic accentuation occur in atrial fibrillation? Pre-systolic accentuation is not occur in the atrial fibrillation. It is other way around. Without atrial fibrillation, in the mitral stenosis, there is a mid-diastolic murmur along with the pre-systolic accentuation. The pre-systolic accentuation occur because of the atrial contraction, because of the late atrial contraction. And in the atrial fibrillation, that late atrial contraction or the early part of the atria which contracts does not occur. So pre-systolic accentuation is absent in atrial fibrillation. Okay. Then other questions are embolic TIA. I don't understand what is this. Carcinoid, I have also already answered. Roth spot, no. Roth spot in the fundus. Jugular veins have a definite point where arteries don't. See, jugular veins have a definite point where the artery don't. When you examine the arteries, then the artery goes, we take the example of carotid artery. The carotid artery you see in the neck, and it goes from the neck to the brain, to the cerebral area. So there is no definite point, means blood goes from the heart to the through that carotid artery and then goes to the brain. There is no upper part. You cannot see the upper part. उसके ऊपर का कोई definite part नहीं दिखाई देगा कि okay यहाँ तक artery में pressure है, यहाँ तक नहीं है. वो pressure वो throughout रहेगा, ऊपर से नीचे तक. While in case of jugular vein, especially the distended vein, you can measure the upper point. You can see the upper point. Okay, jugular vein 5 centimeter है, 6 centimeter है, 7 centimeter है. That depends on the intensity of the venous pressure. Okay. Another question is the hepatojugular reflex. Hepatojugular reflex simply means when you press the lower part of the liver, then the jugular vein, the pressure of jugular vein rises approximately 2 to 3 centimeter. That means when the patient is in the failure, then when you press the lower part of the liver, the JVP, the jugular vein will, the jugular pressure will rise approximately 2 to 3 centimeter above the baseline. That reflex is known as the jugular hepato-jugular reflex. So if any other question is there, you can write it in the chat box. If there is no question, then we can conclude this session. Hello? If there is any question, then please you can write it in the chat box. I can answer that question. And if there is no question, there is one question: why does jugular vein has predominantly inward movement and vice versa? Jugular veins has a predominantly inward movement because the blood goes from the systemic circulation to the heart. Means from the other part of the body, the blood goes to the heart, while in the artery the blood comes through the heart with a lot of pressure. जब आप पंप करते हो किसी चीज को पीछे से, तब क्या होता है? What happen? Then that thing goes with a high pressure. That's why in veins normally there is a less pressure, and in the artery more pressure. Any other question? Palpable thrill. See, thrill means when you put your palm to the chest in this mitral area, if you put your palm in the mitral thrush, then you feel
Sir, the audio is breaking again.
basically it is the murmur, but you cannot say with murmur. Thrill means simply thrill. Thrill means that there is a presence of murmur. Means there is which you feel. You feel the thrill. First you, then second heart sound means gauge where between the
Sir,
am I
the audio
audible?
is, yes, sir. Now you are audible,
Well,
sir, but it is breaking in between.
Krish,
Hello,
everything
sir.
is all right from my side.
Uh,
So I think I should
sir,
continue. So
yes, sir. Yes.
once we identify that there is a presence of thrill, then we have to gauge it whether it is a thrill. So we see the first heart sound is not palpable, but in case of mitral stenosis, the first palpable. So if the thrills come in between the first sound and there is a thrill, not in the diastolic thrill after the second heart sound. I don't know what is the problem. The internet is all right at this point of time. Oh, okay. Any other question? Any other question? There is no question. I will conclusion with thanking you both, Nashish, the second presenter.
Thank you, sir.
And much both presentation. Okay, thank you. Now I can conclude the session. The present. Thank you very much for attending the class.
Thank you.
Thank you, sir.
Thank you.